If you're over 60 and you've struggled with sleep, there's a real chance that somewhere in your medicine cabinet sits a sleeping tablet. Maybe it's zolpidem, known to many as Ambien, or one of its cousins. Maybe it's a benzodiazepine, lorazepam, diazepam, temazepam, alprazolam, names many people know as Ativan, Valium, Restoril, or Xanax, prescribed for sleep or for anxiety. Millions of older adults take these, many of them every single night, and many have been taking them for years, even decades. And here is the uncomfortable truth that too few people are ever properly told. These medications, in older adults specifically, are among the most cautioned against drugs in all of medicine. They appear at the top of the official lists of medications that experts say should be used with great care, or avoided, in seniors, and yet they keep being taken, night after night, because nobody ever sat the person down and explained why, or how to do anything differently. So let me be very clear right at the start about what this video is and isn't. I am not here to frighten you, and I am absolutely not telling you to stop your sleeping tablet tonight. In fact, and this is critical, stopping some of these drugs suddenly after long use is genuinely dangerous. And I'll explain exactly why. What I am here to do is give you the honest, balanced understanding that you deserve. What these drugs actually do, why they hit older bodies so much harder, the fall and memory risks that genuinely matter, why they quietly stop working while still causing harm, the dangerous combinations, the safe way to come off them if you and your doctor decide to, and what actually works better for sleep in later life. And there's one fact about how long these drugs stay in an older body near the end of the first section that explains almost everything else, so stay with me. Let's begin. Let me start with what these medications actually do, because it makes everything else make sense. Both the benzodiazepines, the lorazepam and diazepam family, and the so-called Z drugs, zolpidem and its cousins, work in essentially the same way. They boost the action of your brain's main calming chemical, a neurotransmitter called GABA. Think of GABA as your brain's brake pedal. These drugs press that brake harder, dialing down brain activity across the board, which is why they cause sedation, relaxation, and sleep. And notice something important in that description, across the board. These drugs don't selectively switch on natural sleep, they broadly dampen the whole brain, which is why the sleep they produce is not quite normal sleep. It's lighter in the deep restorative stages, and it's also why their effects spill over into everything else the brain does. Your balance, your reflexes, your memory, your thinking. So these drugs work by pressing the brain's brake pedal harder, producing sedation rather than truly natural sleep, and dampening balance, memory, and thinking along the way. Now here is the fact I promised, the one that explains why older adults are hit so much harder. Here's the crucial fact about age and these drugs. As we get older, two things change. First, our liver and kidneys clear drugs more slowly, so the same tablet stays in an older body far longer. With some of these drugs, and diazepam is the famous example, the drug and its active breakdown products can linger not for hours but for days, which means a tablet taken every night stacks on top of yesterday's tablet and levels quietly build. Second, the aging brain is simply more sensitive to sedatives. The same blood level produces more sedation, more unsteadiness, more confusion than it would in a 40-year-old. Put those together and you get the central problem. A dose that was reasonable at 50 can be an overdose in slow motion at 75. The tablet you take at 10 p.m. is still working on your brain at 10 a.m. and at 2 p.m. as a hangover of drowsiness, fog, and unsteadiness that many people don't even recognize because it's become their normal. So in older adults, these drugs last longer, accumulate, and hit a more sensitive brain, which is exactly why the risks I'm about to describe are so much greater after 60. And the first of those risks is the one that changes lives in a single second. Let me talk about falls because this is the single most important risk. These medications impair exactly the three things that keep an older person upright: balance, reaction time, and muscle coordination. And they do it precisely when you're most vulnerable, at night, in the dark, half asleep, on the way to the bathroom. The research on this is extensive and consistent. Older adults taking benzodiazepines or Z drugs have a substantially higher risk of falls and, most importantly, of hip fractures. And a hip fracture in later life is not a small event. It is one of the most serious things that can happen to an older person, often marking the beginning of lost independence. And here's the bitter irony. People take these drugs hoping to feel better and function better, while the drug itself quietly makes the nighttime trip to the bathroom the most dangerous walk of their life. The next morning hangover matters here too. Unsteadiness doesn't end when you wake, and, for those who still drive, these drugs are linked to a meaningfully higher risk of road accidents, with zolpidem specifically carrying warnings about next morning driving impairment. So the fall and fracture risk is the headline harm. These drugs impair balance and reflexes at night and into the next day, and that's a major reason experts caution against them in seniors. Now let me give you the second major risk, the one people fear most. Let me talk about memory and thinking, because this is the risk people most fear and deserve straight answers about. In the short term, the facts are clear. These drugs impair memory and thinking while they're active in your system. And in an older body, as we've seen, that can be most of the day. This shows up as morning fog, trouble concentrating, forgetfulness, word-finding trouble, and, in some people, genuine confusion. And here's something crucial. In an older adult, this drug-induced fog can look exactly like early dementia. And there are people carrying a quiet fear of Alzheimer's whose real problem is a nightly tablet, which is tragic precisely because it's reversible. These drugs can also occasionally cause paradoxical reactions in seniors, agitation and confusion rather than calm. And zolpidem carries its own famous warnings about sleepwalking and doing things at night with no memory of them. As for the long-term question, whether years of use permanently raises dementia risk, the research has shown concerning associations, and while scientists still debate how much is cause and effect, the honest summary is this. There's enough signal that experts recommend minimizing long-term use in older adults, on top of all the proven short-term harms. So these drugs fog memory and thinking in ways that can mimic dementia, occasionally cause confusion and nighttime behaviors, and carry enough long-term concern that less is better. Now let me explain the cruelest part of the whole story, why they quietly stop working while the risks remain. Here's the part almost nobody is told. These drugs stop working for sleep while continuing to cause harm. It's called tolerance. When you press the brain's brake pedal every night, the brain adapts. It turns down its own braking system to compensate. And within weeks to months, the tablet is producing less and less actual sleep benefit. Careful studies show that with regular nightly use, the genuine sleep improvement from these drugs becomes small or vanishes. People often sleep only marginally longer than they would without them. But, and here's the trap, the side effects don't fade the same way. The fall risk, the fog, the hangover persist. And worse, the adaptation creates dependence. The brain now expects the drug, so if you skip a night, your underbraked brain rebounds. You get rebound insomnia, a night or two of dramatically worse sleep, plus anxiety and restlessness, and you conclude, see, I can't sleep without my tablet, when what you actually experienced was withdrawal, not your original insomnia. That rebound is the engine that keeps millions of people on these drugs for decades, taking a tablet that barely helps anymore. To avoid a withdrawal they mistake for their own broken sleep. So tolerance means the benefit fades while the risks remain, and rebound insomnia tricks people into believing they still need a drug that's mostly just preventing its own withdrawal. And that brings us to the most important safety rule of this entire video. Here is the rule you must never break. Never stop these medications suddenly after long-term use. If you've been taking a benzodiazepine or a Z drug regularly for months or years, your brain has adapted to it, and stopping abruptly doesn't just cause bad sleep, it can cause serious withdrawal, severe anxiety and agitation, tremors, sweating, a racing heart, and, with benzodiazepines especially, the genuine risk of seizures, which can be dangerous, even life-threatening. This is not a drug you quit cold turkey, ever. Coming off is absolutely possible, People do it successfully all the time, and most feel clearer, steadier, and sharper on the other side. But it must be done as a slow, gradual taper, reducing the dose in small steps over weeks to months, under your doctor's guidance, sometimes switching to a longer-acting drug first to smooth the process, and going at a pace your body accepts. Expect some bumpy nights along the way. They're temporary, and they're withdrawal, not proof you need the drug forever. So never stop suddenly after long use. Because of withdrawal and seizure risk, always taper slowly with your doctor. And know that the other side, a clearer head and steadier feet, is genuinely reachable. Now let me cover the combinations that multiply the danger, and then what actually works instead. Let me give you the dangerous combinations, because these multiply every risk we've discussed. The first and most serious is combining these drugs with opioid painkillers, codeine, tramadol, oxycodone, morphine, because both suppress breathing, and together they can dangerously slow it. This combination carries the strongest official warnings and has cost many lives. So if one doctor prescribes your sleeping tablet and another your painkiller, each must know about the other. The second is alcohol, which works on the very same brain systems. A nightcap plus a sleeping tablet is not two mild sedatives. It's one dangerous one, deepening sedation, worsening breathing suppression, and multiplying the fall risk. Alcohol and these tablets should simply not share an evening. The third is stacking sedatives, a sleeping tablet plus a sedating antihistamine, or a nighttime cold remedy, or certain anxiety or nerve pain medications like gabapentin, all adds up in an older body. And the fourth is sleep apnea. If you snore heavily and stop breathing at night, these drugs relax your airway further and suppress the brain's wake-up response, making apnea worse and more dangerous, which matters because so much untreated apnea hides behind insomnia in later life. So never combine these drugs with opioids or alcohol. Watch for sedative stacking, and be especially cautious if you snore and gasp at night. Now, the hopeful part, because there is a genuinely better answer for sleep after 60. Here's what actually works, and this isn't a consolation prize. It's the treatment that outperforms the pills. The gold standard treatment for chronic insomnia, the one guidelines now recommend first, before any tablet, is not a drug at all. It's a structured retraining of your sleep called CBT-I, cognitive behavioral therapy for insomnia. And in head-to-head research, it beats sleeping pills for lasting results because it fixes the underlying pattern rather than sedating you past it. Its core moves are things you can genuinely begin yourself. Keep a fixed wake-up time every single day because a stable rising time anchors your whole sleep rhythm. Don't go to bed until you're actually sleepy, and don't spend 9 or 10 hours in bed chasing 7 hours of sleep, because all that extra bedtime creates the broken, shallow sleep you're trying to escape. If you can't sleep after about 20 minutes, get up, sit somewhere dim and calm, and return only when sleepy, retraining your brain that bed means sleep, not frustrated lying awake. Get morning daylight and daytime activity. Cut the late caffeine and the alcohol. Keep the room cool and dark, and expect the change to take a few weeks because retraining beats sedating, but it isn't instant. And know the honest truth about age and sleep. Sleep naturally becomes lighter, shorter, and more broken in later life. An older adult who wakes a couple of times but functions well in the day doesn't have a disease needing a nightly sedative. Sometimes reassurance is the treatment. There are also other medication options with different risk profiles, melatonin-based approaches and others, worth discussing with your doctor as part of a taper plan. But the foundation is the retraining. So the better answer is CBT-I and sleep retraining, fixed wake time, less time in bed, out of bed when you can't sleep, light and activity by day, and it outperforms the tablets where it counts, in lasting sleep without falls and fog. Now let me be clear about when to talk to your doctor. Let me be very clear about when to see your doctor. See your doctor at a routine visit if you've been taking any sleeping tablet or benzodiazepine regularly for more than a few weeks, and simply ask the question, is this still right for me, and what would a taper plan look like? That single conversation is one of the most valuable an older adult can have. And if you're on the official caution list's drugs, Your doctor will know exactly why you're asking. See your doctor promptly if you're having falls or near falls, morning grogginess, memory problems or confusion, or if anyone has noticed you doing things at night you don't remember. See your doctor before ever combining these with new painkillers, and tell every prescriber and your pharmacist everything you take. Seek urgent help if someone on these medications, especially combined with opioids or alcohol, becomes extremely drowsy, unrousable, confused, or is breathing slowly or shallowly. That's an emergency. And never stop suddenly after long-term use. The taper conversation is exactly what your doctor is for. So a review conversation for any regular use, prompt attention for falls, fog, or night behaviors, urgent help for deep sedation or slowed breathing, and always taper. Never quit cold. Let me paint you two pictures, because they hold the whole message. First, picture a woman of 74 who has taken lorazepam at bedtime for 11 years. She'd tell you it barely works anymore. She still wakes at 3, but the one night she skipped it was so awful she never dared again. She's had 2 near falls on nighttime bathroom trips. Her daughter has noticed her morning fog, and privately, she's been terrified it's early dementia. Then her doctor, during a medication review, gently explains everything you've just learned: the tolerance, the rebound trap, the fall and fog risks, and offers a slow taper with sleep retraining alongside. It takes 4 months, with some rough patches, and on the other side she's sleeping about the same as before, but she's steady on her feet, her head is clear, and the dementia fear lifts. It was the tablet all along. Now picture the contrast. A man of 71 on nightly zolpidem who's prescribed codeine for a back strain by a different doctor who didn't know about the zolpidem, and whose wife finds him barely rousable, breathing slowly, and calls for help in time. 2 stories, 1 message. These drugs demand respect, communication, and a plan. And with those, there's a genuinely better life on the other side. And let me speak briefly to those caring for or close to an older person on these medications. You may notice what they can't: the morning fog they call normal, the unsteadiness on night trips, the memory slips, the personality flattening. You can help by encouraging that one conversation with the doctor: is this still right for me? And by supporting a taper patiently if they choose one, expecting bumpy nights and reassuring them it's withdrawal passing, not failure. Guard the combinations fiercely, no alcohol with the tablet, and make sure any new painkiller prescriber knows about the sedative. Make the night path safe regardless: nightlight, clear floor, nothing to trip on. And know the emergency: extreme drowsiness, unrousability, or slow, shallow breathing means help now. Helping a loved one through this may be the single biggest thing you ever do for their remaining years of clarity and independence. Let me draw this all together. Sleeping tablets and benzodiazepines, the zolpidems, lorazepams, diazepams, and temazepams, press the brain's brake pedal to produce sedation rather than true sleep. And in older adults, they linger far longer and hit a more sensitive brain, which is why they sit atop the official caution lists for seniors. Their real costs are falls and hip fractures, memory fog that can mimic dementia, next-day impairment, and, with time, tolerance that erases the benefit while dependence and rebound insomnia lock people in. They must never be stopped suddenly after long use, because withdrawal can be severe and even dangerous. The way out is a slow taper with your doctor. They must never be mixed with opioids or alcohol. And the genuinely better path for sleep after 60 is retraining, CBT-I, a fixed wake time, less time in bed, and patience, which outperforms the pills where it matters. So here's what I'll leave you with. First, if you take these regularly, don't panic, and don't stop tonight. But do book the conversation: is this still right for me? Second, understand tolerance and rebound. The tablet that barely works is probably also the thing wrecking the nights you skip it. Third, guard absolutely against the combinations, opioids and alcohol above all. Fourth, if you come off slowly, with your doctor, expecting temporary bumps and a clearer, steadier self on the other side. And fifth, invest in the real fix. Retrain your sleep with a fixed wake time, less time in bed, morning light, and daytime activity, and accept that older sleep is naturally lighter without reaching for a nightly sedative. These medications have their place, short-term, occasional, carefully supervised, but a nightly tablet rolling on for years in an older body is a risk quietly compounding, and you deserve better. So take care of yourself, ask the question, protect your nights and your mornings, and never stop suddenly. And because reviewing and tapering these medications requires a doctor's individual judgment, please treat regular use as your reason for a proper medication review with your own physician. Treat falls, fog, or night behaviors as prompts to have it soon, and treat deep sedation or slowed breathing as an emergency. If this helped you, please give it a like and subscribe and share it with someone you love who takes a nightly sleeping tablet, because this conversation could give them back their steadiness, their clarity, and their confidence.